So what I thought we would talk about this morning, if it's okay with you guys, was a little bit about hybrid procedures. So I don't know, has anyone talked to you guys about hybrid stuff?
No, and that's exactly why I got up early.
Okay.
Ooh.
So we probably won't have time to also talk about transcatheter stuff, so maybe on a different morning we'll talk about that. But I figure, we're doing enough hybrid procedures now in lots of different forums that you guys take care of them. So I thought we'd just talk a little bit about the physiology and then what are the things that we look for in the ICU, kind of in the peri-procedural period. So the first thing is we're going to go through why you do a hybrid procedure. Okay, so the general gist, why do you think, we're going to make this a little bit interactive. So why do you think, what would be the advantage of doing a hybrid procedure versus just doing like a regular old surgery? So like what would be theoretical advantages of doing a hybrid procedure?
I can't say, but I think we tend to do hybrids on the ones that are really tiny, the smaller babies.
Yep.
Size,
Yep.
give them time to grow.
Yep.
Their body. It's better for them when
Yep.
they're bigger.
Absolutely true. So the main advantage that we think, and we don't even really know this yet, is avoidance of cardiopulmonary bypass. So we know that bypass in neonates is higher risk. We think that over time we'll learn that it has a pretty negative impact on their neurodevelopment. We don't know that yet, but we're trying to figure that out. But lots of studies have looked at outcomes of kids. We know that when you have to have bypass early in life, that's a bad thing. So one of the ways that doing hybrids is that you avoid bypass in the neonatal period and might make kids a little bit better. And what we use hybrids, and I guess we should go step back a little bit and just talk about what the definition of a hybrid is. So a hybrid is not, I think when we hear the word hybrid, we think of hypoplast, but that's not really what a hybrid is. So a hybrid is anytime you're using cath and surgical techniques together to accomplish a goal. So anytime that you're using cath techniques in the operating room or operating techniques in the cath lab, that's really a hybrid procedure because you're joining two fields. So we actually use it in lots of different settings. So hypoplast is the most common hybrid that we talk about, but the other lesions that we do, pulmonary atresia, intact ventricular septum, so we've had a couple kids here recently that we do a hybrid procedure on. We do it for intraoperative stenting and pulmonary artery angioplasty. And so typically a cath technique or a surgical technique, we do them together. Also VSD closures, we have a kid in here who had a hybrid VSD closure. So we actually do it in a couple different settings, but it's important to know that it's not just hypoplast. We're going to talk mostly about hypoplast because that's the one that you're going to see the most, but when someone says the patient had a hybrid, that doesn't actually tell you anything about what their anatomy is or anything like that, okay? So it's important you say what their baseline anatomy is and the fact that they have a hybrid. So, we think the major advantages that it avoids cardiopulmonary bypass in the neonatal period, and there's a lot of data that's coming out saying that's good for kids. So at Michigan, if you were at Columbus at Nationwide Children's Hospital and there was a hypoplast that was born, there's a pretty good chance that patient's going to have a hybrid procedure as their stage 1 operation. We think that our outcomes are good with our surgical outcomes are really good with our stage 1. So we only do hybrid procedures on the patients who traditionally haven't had as good of outcomes. And those are the high-risk patients. And so one of the things, as you mentioned, was low size. So really small kids, usually less than 2 kilograms, are known to have a high surgical risk. Some of the other things that we know increase your surgical risk is some specific things about your cardiac anatomy. So kids who have LV sinusoids, so where you basically have coronary problems, that's a high risk factor. Kids who have really depressed right ventricular or good ventricular function, when that function's not good, or they have severe TR, that's high risk. Any kid who's got other organ system problems, genetic malformations, brain issues, kidney trouble, those all put kids at higher risk of having any type of operation, especially in Norwood. So those kids all go into the high risk category, and prematurity, there's some other things too. So put them into the high risk category, and so we then think about doing a hybrid procedure. So, and that's kind of been our institutional way in the last few years, and that's probably what we're going to continue because our surgical outcomes are really good, and now by using a hybrid, we think we're taking the high risk kids and getting their outcomes a little bit better. So, speaking specifically about hypoplast, we're going to talk a little bit more about this, and so there's a little, I'll hand you guys this thing.
Thank you.
Yeah, it's okay. Sarah, we have enough, Sarah. One more, Jeff, thanks.
So I didn't have a copier, so I re-hand drew every one of these. No, I'm just
You're
kidding.
so awesome.
No, these are actually copies, but I did draw the pictures. But so there's 3 pictures on here. The one on the left is obviously just a baseline hypoplast. The middle one is a typical Norwood VT shunt, and the third one is a stage 1 hybrid. Come on in.
They got extra?
Yeah. So so we'll kind of go through the individual stages, and so you can see that a Norwood VT shunt and a hybrid stage 1, the goals are exactly the same. It's just how the blood is flowing is a little bit different. So let's start on the very left picture. So you can see you have your blue blood coming back from your SVC to your right atrium. You have your pink blood coming back from your 4 pulmonary veins. So there's, in this case, I drew mitral atresia and aortic atresia, so there's no mitral valve and no aortic valve. So all the blood coming back from the pulmonary veins crosses the atrial septal defect. You get mixing of that blood in the right atrium and the right ventricle. The blood's pumped out your pulmonary valve, which is the only valve you have, and then it has some choices, right? So it either goes to the lungs through the pulmonary arteries, or it goes across the ductus into your aorta. Once it gets in your aorta, it actually goes down to your descending aorta and actually also backfills your ascending aorta. So why does the blood have to go backwards into your ascending aorta? What's the most important part of that you're trying to get blood flow to?
Your head, brain.
So your brain, and what else? What else is at the very base of your aorta?
Coronary.
Coronaries. And that's going to become important as we talk about the next 2 stages. So it's always very interesting to me, and kids who are hypoplastic, I mean, they have these 1 millimeter ascending aortas, but their coronaries still come off of those ascending aortas. So somehow they get enough blood vessels to go down there to get blood to those coronaries and survive. I mean, it's amazing any of these kids survive, at all. I mean, much less after we do all these things to them. So, so that's kind of what a hypoplast looks like at the baseline. And you guys know, the way that we try to get blood to go preferentially to the body versus the lungs. We try all our milrinone, subambient FiO2, things that try to encourage blood to go across the duct and to the aorta instead of to the pulmonary arteries where the kids get over-circulated. So if looking at the second picture, so a typical Norwood. So with the Norwood, the beginning part's the same. Blue blood comes back from IVC and SVC. Pink blood comes back to the pulmonary veins, crosses over the atrial septum, mixes in the right atrium and the right ventricle, goes out the pulmonary valve. So now what you've done is you can see at the very bottom, you've basically created a Y connection between your native aorta and your native pulmonary artery. So that's that DKS anastomosis that everybody talks about. That's that Y connection right there. So now your blood to fill the coronaries doesn't have as far to go. It just has to basically make that short turn into your ascending aorta. Then it goes, the rest of everything is all aorta. So it all goes around what we call the neo-aorta. And then from the innominate vein, which is on the upper left of the picture, goes down the VT shunt, and that's how you fill the coronaries. So the important thing is the 3, so on the bottom here I tried to write what the 3 key steps are to a Norwood procedure. So what you need to have is you need to have unobstructed pulmonary venous return. And so during that procedure, if there wasn't an ASD or the ASD was small, they make a big ASD, so that their atrial septectomy. And that's very important. So if you have a restriction to how much pink blood's coming across, you're going to be really blue. Okay. Number 2 is you have to have unobstructed systemic blood flow. So that's why we do the Norwood arch, to basically make a nice big connection that connects your right ventricle to your right ventricle is now your systemic pumping chamber. And the third thing is you need to get some source of pulmonary blood flow, which is in this case your VT shunt or a sano. But the important part is that it has to be a restricted source of pulmonary blood flow. So if you had an unrestricted source of pulmonary blood flow and your blood vessel had a choice between going to the lungs and the body, it's always going to choose the lungs because the lung is the lower resistance pathway basically. So blood cells are pretty stupid, they just go wherever it's easier. And so they're going to go to the low resistance circuit, which is always going to be the pulmonary circulation. So by creating a VT shunt that's small, or a sano shunt that's relatively small compared to the rest of the body, it's going to choose to go to the systemic circulation preferentially over to the systemic circulation. Now sanos are a complete different ballgame, and how we talk about that, we're going to kind of ignore that for right now. So looking at the far right picture, so the right picture, we're going to kind of go through the procedure a little bit. So the steps of the procedure are exactly the same. We want to create an unobstructed ASD, we want to have unobstructed systemic blood flow, and we want to have restricted pulmonary blood flow. But we have to do this all without doing surgery. So the way that we do this is, for unobstructed ASD, so we either do a atrial septostomy or put in an atrial septal stent, and that depends a little bit on how much restriction there was and how thick the atrial septum is. But some kids will have an atrial septal stent, and some kids will have a septostomy just to increase their blood flow. To create unobstructed systemic blood flow, because you're not reconstructing the aorta, you're just trying to create a pathway for the blood to go. So the blood's still going to go out the pulmonary artery, but you're going to trick it to keep the ductus open and make it look like it did when the kid was first born by putting a stent in the patent ductus arteriosus. So you stent the ductus, and then you want to restrict the pulmonary blood flow. So the way to restrict the pulmonary blood flow is we put bands on. Okay, so by putting bands on the pulmonary arteries, you disencourage blood to go to the pulmonary arteries and encourage it to go across the duct. Okay, so going through this picture on the right, again, looks the same at the beginning. Blue blood coming back from IVC and SVC, pink blood coming back from the pulmonary veins. Blood comes across an unrestricted atrial septum, which in this case is just an open septum, mixes in the right atrium, right ventricle, goes across the pulmonary valve. So it first goes out to kind of the MPA region, then has a choice, either go out to the branch PAs or go across the ductal stent. With the PA bands on, you try to encourage it to go across the ductal stent. So once across the ductal stent, you notice that this looks a lot like the initial anatomy, right? The blood has a choice whether it goes down the descending aorta, and then some of the blood's going to go retrograde into the ascending aorta and fill the coronary. So that looks a lot like initially. But again, you've accomplished your same three goals by putting in a PDA stent, bilateral pulmonary artery bands, and creating some type of wide open atrial communication. Okay, does that all make sense?
Mm-hmm.
Okay. So when the kids are in the ICU, the management is very different though. So management of a hybrid is much different than management of a hypoplast that's had a Norwood and VT shunt. So let's just talk quickly about blood pressures. So, because I think this is one of the things that is kind of confusing about the two different anatomies. So if I told you, Mallory, that the blood pressure in a straight Norwood VT shunt, that the right arm blood pressure was 100, but the leg blood pressure was 50, what would be your main concern?
Restriction in your PDAs.
Shouldn't be your PDA, because your PDA will actually be gone in a VT shunt patient.
Oh, right, okay.
We ligate that, that's part of the procedure. But say for instance this is a patient with an otherwise normal kid who's just any other kid, normal healthy kid who's got a blood pressure of 100 in the arm and 50 in the leg. What's the diagnosis?
Cohort?
Cohort, right? So it's some type of obstruction in the aorta. So in a Norwood, you should have a nice wide open aorta, right? Because you just created that. So if you have a blood pressure gradient between your arm and your leg, importantly that your leg is lower than your arm, you're worried that you have recoarctation. So you're going to have narrowing somewhere along your Norwood pathway. So if in a hybrid patient, we actually worry about the opposite thing. Okay? So in a hybrid patient, the arch is actually all the same stuff that was there initially in the stent. And the stent is in the PDA. So the arm and the leg are more important going the opposite way. So if I told you that your arm blood pressure is 50, but your leg was 100, so what type of coarctation? You'll hear this buzzword all the time.
Say that again, your arm is 50.
So your arm is 50, your right arm is 50, and your leg is 100. Are you worried or not worried? Well, I guess let me step back. In a normal kid, what's a normal blood pressure in your arm and your leg? Not the exact numbers. Are your legs higher or lower or the same as your arms?
I think your legs are lower.
Your legs are actually higher in normal kids. Because if your legs are lower, then you have a cohort. Okay? So we always check blood pressures in the outpatient setting, and your legs should always be the same or higher. The reason for that is multiple reasons, but you get this thing called pulse amplification as your blood flow flows down the column of blood, but your legs are typically higher than your arms.
I didn't
So, but they should at least be the same. If they're not the same, so when we check them in clinic, if your legs are ever less than your legs in almost anybody, we're worried. So, so your legs should be the same or higher as a general rule. And that's true in a Norwood VT shunt. Your legs should be the same or slightly higher than your arms. But in hybrids, it's a little bit different. So in this case, your leg and your arm should be exactly the same, right? Because the blood flow, if you look at this, as the blood leaves that stent, okay, crosses the stent, and is going to the head and neck vessels. So again, this vessel up here, I'll kind of show you, the one that's to kind of the leftmost of the screen. Sorry. Hi, Jeff. Hi.